Sir, number program is now live on YouTube also.
Oh, very good. Very good.
So that others can see. Actually, it's not limited just to. Ravi sir, inga vandirukara.
வந்துட்டார் சார், வந்துட்டார். ரைஸ் பண்ணிருக்காரு.
இருந்தாலும் யூடியூப்ல ஒன்ன பார்க்க முடியாதுல்ல திருமுருகனை. நம்ம இவரை பார்க்க முடியாது, பாஸ்கரனை பார்த்துக்க முடியாது.
சாரை பார்த்தா சார் இன்னைக்கு பாக்குறது ரொம்ப நாளைக்கு அப்புறம் பார்க்கணும்.
ஆமாமா, சார் நம்மள அபிமானி. சார் கரெக்டா?
இல்ல சார்,
பாஸ்கரன் கேள்வி கேட்காத ஒரு இதுவே கிடையாது. ஐ அப்ரிஷியேட். Always he'll ask one question or two questions to the speaker.
Sir, ஆரம்பிச்சிடலாம் சார்.
ஆரம்பிச்சிடலாம். இப்ப யார் ஃபர்ஸ்ட் என்ன?
விளம்பரம் ஆரம்பிச்சிடலாம்.
Okay sir. Sir, good morning sir. My all teachers, my seniors, எல்லாருக்கும் sir ஒரு வணக்கம் and happy new year sir. And I thank everyone for giving me an opportunity to come into the forum sir. For a long time I have been away from Pondicherry. So Tirumurugan sir he has given a big responsibility for our team. So and today Pondicherry there is good amount of rain, the weather is good, and I think it's a good time to start our 2021 schedule also sir. So we can begin with our IAP prayer meeting sir. Prayer. So the pediatrician's prayer. All can read with me. Grant us the quality of holistic healing. May we humbly realize how privileged we are in being bestowed with the ability to alleviate suffering. May we be emissaries of health, learning, charity, love and peace to all children and their families, irrespective of status and creed. Give us the wisdom, understanding, the change the things we can, retain the good, and accept within reason the things we cannot change. Grant us your blessings, grace, mercy in all situations, at all times, and amidst all people. Thank you. Sir, I would like today's proceedings to start with our immediate past president, Dr. Bhaskaran sir. So you can start the proceedings, please.
Thank you. Respected senior professors, Dr. Srinivasan, Professor Nalli Madam, Professor Mahadevan, Madam Chidambaram Madam, and my dear colleagues, it gives me immense pleasure to address this meeting. I was president for the past 2 years, and 19 and 20. And actually, when this IAP Viluppuram Pondicherry chapter was first launched in Annamale, and I was the first president. Professor Srinivasan installed me as the president. At that time, I told, just like our Indian president, we don't have much of a president has not much to play, much role to play. Actually, the secretary has to look after it. Like that, I was very, what to say that, Arun Kumaran was my best man, actually. That's why we had a very good tenure in this one, and we achieved some great prize. The first time IAP Viluppuram branch and Viluppuram Pondicherry branch achieved something. I hope that this year also this team will do that. Thank you very much.
Thank you, sir.
Thank you, sir.
Sir, I would request Dr. Shanmunathan, sir. He's been the new team president. So for him to start the meeting and say a few words. Sir?
Thank you, sir. Thank you so much for your good morning, everyone, sir. It's immense pleasure to welcome you all for the join today. First of all, I wish to Happy New Year for 2021. In today gathering, I would like to immense work that is existing work of our team members. Previous existing members like Dr. Bhaskaran sir, Dr. Arun Kumaran sir, and Dr. Raju Nagam sir and team, branch activities for best branch activities. Now I am grateful to introduce our newly elected members for our IAP Viluppuram branch. And Dr. Ravichandar sir for our president-elect, as well as Dr. Chitra Vasudevan madam for vice president, Dr. Ilamaran as a secretary, Dr. Vinod Kumar as a treasurer, and Dr. Anand Kumar as a joint secretary. And our existing EB members, Dr. Pani Rai sir and Dr. Pani Raman sir from Vilupuram, Dr. Tirumurugan sir, as well as Dr. Narayan sir from Pondicherry, and Dr. Vaidiling sir from Kalakurchi. In this in this regard, some new action plan for this 2021. It's mostly we have to decide and focus on mainly in social activities about the school health program as well as the adolescent activities in this near future. It's a very important thing. Second thing is we put forth some steps to buy some small land and build the IAP Vilupuram Pondicherry branch for our own activities. And our suggestions supposed to welcome. And maximum effort towards about the upcoming, the success of upcoming Pedicon 2021 is very important. That the next thing is we expect you support and the cooperation for the team for upcoming funds. Thank you so much. Over to Dr. Ilamaran sir. Thank you.
Thank you, sir, Shanmunathan sir, for giving an intro of our team. And I hope, sincerely hope that we will be able to go at least 1 to 10 steps ahead of the previous year and be a benchmark for the rest of India. So that is what we hope for, sir. And with all the blessings of our seniors, teachers, and especially Dr. Tirumurugan sir, because he is like a guiding beacon for us in all our activities. So we hope we will achieve whatever we plan for, sir. So with that, I think we can start with our CME activity, CME for today. Shall we, sir?
Yeah.
Yes,
I think we can start now. We're already kind of falling behind. Yeah, please start.
Okay, sir. So today's ma'am, I'll be giving a short introduction for Madam Chidambaram because I may be the last person to introduce because I'm new for this team. So Madam has been here for decades together, and she's a well-known. Chidambaram Madam has been a well-known for pediatrician in our region. So she's known for her poetry. I mean, through the words of Nalli Madam, Srinivasan sir, and Madhavan sir, I come to know that Madam has written a lot of poetries in as she was in JIPMUM. And over to Madam for her topic.
Sir, excuse me, sir.
We'll be talking on, the private practice, non-institutional private practice, how her personal experience has been. Over to Madam. Sir, you want to say a few words, sir?
Yes, sir. Just 1 minute, sir. Dr. White, Dharmaling sir is a central EB member. So just I will just introduce things. Just I will miss that thing. No problem. Thank you, sir. Thank you.
Hello? Yeah. Who do you want, please?
Thank you,
Madam?
sir. Thank you, sir.
Only on the line.
Madam Chidambaram, Madam. Good morning, ma'am.
Good morning.
May I know who's speaking? Sorry, wrong number. Wrong.
Not recording.
Chidambaram madam.
Yeah, just a moment.
Yeah, இல்ல உங்க ஷேர் ஆகுது இல்லீங்களா? அதுதான் just I just want to make sure it's getting shared.
A very good morning to. Can you hear me, please?
Yes, ma'am.
Yes, ma'am.
உங்க screen share ஆகல madam.
A very good morning to all the people who have assembled to listen to me. A very happy new year to you all.
Yes, ma'am.
I'm indeed thankful to Dr. Shanmuganathan, Dr. Ravichandran, Dr. Lamaran, Dr. Vinod Kumar, and Dr. Anand Kumar, and of course, the esteemed Dr. Thirumurugan for having me on this show. People will know them as virtual flyers, and later on, the Kodungol Archi Mandan Corona, if he permits, we will all be able to have real-time experiences with these stalwarts. This, I would also think that, I would like to say that Dr. Sandil and his team of Suresh Balan and Dr. Rajendran have, by their erstwhile and exhausting efforts, raised the bar in the previous year with a lot of CMEs and conferences virtually. And we do have to do a lot of work to set new benchmarks. And as Dr. Elamaran said, let's have a go at it. When Dr. Thirumurugan requested me to talk on this subject, after initial forms, I accepted, but I felt, but I asked him, I requested him to give me the first slot at speaking, with the fond hope that many people will not tune into the speech, and also that I will not fail into insignificance if I had to talk after stalwarts like Dr. Mahadevan and Dr. Elamaran, etc. So this topic, so let's coming to the topic proper. Non-institutional pediatric practice. Panacea or Pandora? இந்த மாதிரி ஒரு டாபிக்கை கொடுத்து என்ன நல்லா மாட்டி விட்டுட்டாங்க. The only way I can talk about it is only from my own experiences. And I feel that I might be able to tell you something constructive.
Madam, can we have your video, madam? Is it possible?
Video earlier.
Varla.
Oh, I thought I'm okay. Just a moment.
Video வந்துருச்சு madam.
இப்போ screen வருதா?
Screen வரல madam. Screen வரலையே. இல்ல உங்க ஸ்கிரீன் வருது. நீங்க ஏதாவது பவர் பாயிண்ட் ஏதாவது ப்ரொஜெக்ட் பண்றீங்களா?
இல்ல 2 ஸ்லைடு தான். 4 ஸ்லைடு. அது வரலையா? இதுல போட்டு. Now can you see me? I think the screen is not coming.
The share screen la போங்க. Share screen
la போட்டா.
அத இது பவர் பாயிண்ட் கிளிக் பண்ணுங்க.
பவர் பாயிண்ட் ஓபன் பண்ணிட்டீங்க.
பண்ணி பார்த்துட்டேன். அது என்னமோ தெரியல.
மேடம் எனக்கு வாட்ஸ்அப்ல இமெயில் எனக்கு அனுப்பிச்சு விடுறீங்களா? நான் பண்றேன்.
திரு அப்படியே பேசிட்டோம் மேடம் பேசிட்டோம் அப்படியே பேசிட்டோம்.
இல்ல அவங்க she is gone out. She is coming back in.
But I'm stuck here. Your time. Actually, I can talk only from my experiences over the years. I have
Okay,
spent
இல்ல வரல உங்க ஸ்லைட் எல்லாம் ஓகேனா பேசலாம் மேடம், அப்படியே பேசலாம். வருதா?
ஓகே, நான் அப்படியே பேசுறேன். என்னன்னு தெரியல, நான் ஷேர் ஸ்கிரீன் போட்டு பவர் பாயிண்ட் போட்டு பார்த்தேன், வர மாட்டேங்குது.
நீங்க உங்களது எனக்கு அப்படியே வாட்ஸ்அப் அனுப்ப முடியுமா? வாட்ஸ்அப் இமெயில் அனுப்ப முடியுமா?
டிலே ஆகும் இல்லையா? பரவாயில்லையா?
அனுப்பிச்சீங்கன்னா ஒரே நிமிஷத்துல அனுப்பிச்சு விட்டுருவேன். நான் உங்களுக்கு டெக்ஸ்ட் பண்ணி விடுறேன் என்னோட இதை ரைட் நோ. ஜஸ்ட் நோ ஐ வில் டு இட். நீங்க ஸ்டார்ட் பண்ணுங்க மேடம்.
அதெல்லாம் அவங்க டெக்னிக்கலா கஷ்டம்டா. அவங்க கூட பேசட்டும், அப்படியே பேசட்டும் மேடம்.
பேசுங்க மேடம், பேசுங்க மேடம், ஒன்றும் ப்ராப்ளம் இல்லை. பேசுங்க.
So as I was saying, it's only my experiences, and I have to delve into it and give a few pointers which might be useful to the young budding doctor who has passed out and he is at the crossroads, whether to go to the institution or to a non-institutional setup, or go to or have his own private practice, or do some other job, as many people are diverting nowadays from their original intent. In this, I have to talk about the timeline in my life, or rather to put it in pediatric parlance, the journey of my life in the medical field. And since I have worked in both the institutional as well as in the non-institutional fields, I feel that I am qualified to give a few opinions on this. I finished my undergraduation in Madras Medical College and my post-graduation in JIPMA. I joined in physiology department in JIPMA first, where I had the acquaintance of the now pediatric greats, Dr. Mahadevan and Dr. Vishnu Bhatt. Later on, I joined the Department of Pediatrics, JIPMA. The esteemed Dr. Srinivasan was my classmate, and Dr. Nalini and others were my contemporaries. Dr. Srinivasan, a very studious person, was the bounding hare that bounded to victory and achieved national and international fame. Well, I, the tortoise, stopped after the first lap of the DCH. So this is a hare and tortoise story in reverse. That period was a nostalgic period, and I made very good friends there. And after DCH, since I was not able to do further post-graduation, I joined maternity hospital, and I was employed not because of my DCH, but because of my MBBS, and posted to work in the, was posted to work in the general wards as a general medical officer, as a civil assistant surgeon. Luckily for me, there was the maternity hospital was under dual control, one from JIPMA and the other was from state. And I was associated with legends like Dr. Prabhavati, Dr. Nayak, Dr. Rajaram, and Dr. Asha, Dr. Soundararajan. And it was the senior members who decided that I will be wasted on the field of OG, and asked me to look after the newborn of the hospital. So I was managing the hospital as a single person, and I got a lot of experience there. There were only postnatal wards and there was not a nursery. With the help of the then medical superintendent, I was able to partition a portion of the postnatal clean ward and converted it into a nursery. And I had some 5 beds there with cots with 100-watt bulbs for heating the babies. And believe me, I got a lot of good results. Later on, a proper neonatal nursery was started, and I think now it has become so. I had the good fortune of initiating this process, although in a very small way. The work here as such was very strenuous because it was a 24/7 job. There were about 40 to 50 odd deliveries per day, and I was only a pediatrician on call. And there was no difference between day and night. And the ambulance drivers did not even have to ring the bell. They just have to change the gears and they will make that gurr noise, and everybody in the neighborhood and including my 2 children used to wake up. That was my life. And but the patient care, people were very happy with your care. And I learned most of breastfeeding from the grand multis who delivered there, which is a rare opportunity and it is not available nowadays. As it is a 24-hour job here, after I joined this side, in the non-institutional side, here also there was this 24/7 job. And here, in addition to getting newborn calls, I have to attend pediatric calls and queries also. And this is happening till date. I learned the meaning of the word tiring only when I was in maternity hospital, because it was really exhausting. This went on for some time. And I had a few satisfying experiences also. There are many of them, but to quote one or two, there are some instances where you really feel that you have served your life's purpose. In one incident, there was this newborn. On one particular day, some 4 or 5 newborns had been delivered at almost the same time. And from one baby, the cord ligature had slipped, and the baby had bled into the cot. There was no blood to collect from the baby. So the umbilical vein was cannulated, the blood was taken from the cot, sent for grouping and cross-matching, and the baby was saved. That was a real drama. Similarly, I've seen many asphyxiated babies who you feel like giving up, but you just continue the treatment. Because in those days, we did not have the state-of-art equipment, the hypothermia, etc. at that time. And we just had to manage with what we had. And in one of those babies, which recovered after almost a week, for 3 days it was comatose, and after a week it recovered. And of course it was lost to follow-up. Later on, when I was transferred to Karaikal after my stint in maternity hospital, I happened to meet that family. And that girl aged 10 years welcomed me, but she had a stutter in her speech. So I thought it was the remnant of the hypoxia which she suffered. But pleasantly surprised when I saw her a year ago at a new medical center. Her stutter had disappeared. And she had taken the most vocal of professions, that of a lawyer, and she was doing very well. It told me never to give up on anyone and never to play God to say this baby will not have any sequelae. We have to do our bit and do it sincerely. I have had such similar experiences. Learning wise in the institutional sector, there wasn't much. Of course, there was a lot of forums active then also, but due to financial constraints, could not attend most of them. In this context, I would like to mention Dr. Rajaram, who worked with me. He was the professor of obstetrics and gynecology. We researched a paper. We did a retrospective study of babies born 2 kg and below and the survival rate. And we had a good paper. And it was accepted by the Oceanic Congress in Australia. And they invited me to present after seeing the abstract. But due to financial constraints, could not make the trip. And that was the end of my academic adventures. Recognition wise, it was, I had only ward work and a meager postnatal OPD, which from where we could see only umbilical sepsis and no patients could get access to us or know about us. That was totally different in the non-institutional sector. My work-life balance as such in the institutional sector, as I said, it was a tiring job and you don't know when you're getting to be called for any case. There was and you have to lose quality time. I had to lose quality time with children and also my family and aged parents and in-laws who are with me. Coming to the financial security aspect, in government service, after 20 years, I was able to retire because I was able to get a pension, although it was very small, and I had to retire before the pay commissions. That was today's doctors who retire get a very good pension and they are all well off. But since I retired before these commissions, I was not much benefited by it. But all this was overshadowed by my stint at New Medical Center, which I joined subsequently. Here also it was a 24/7 job, as I mentioned earlier. But here I was getting paid individually for every case, and there was a lot of interaction with all my colleagues. And whatever said and done, if there is a team consisting of an obstetrician, an anesthetist, and a pediatrician, whenever you are on call, you don't feel like giving up on them and saying, no, I won't attend. So it was a nice experience, although it was exhausting for most of us. And here also I had a lot of experiences and patient. But here there was a patient continuity which was lacking in the institutions. In the institutions, it's a floating population. You may see the patient with a 2-day fever on Monday, and then the other day, and on 5 days later, some other doctor sees the patient. So There is no follow-up for any single patient in the OPD at least. In the inpatient, that is a different story altogether, because they are admitted in particular units, and you can, even if you have admitted them, you can always go back and check. But in the non-institutional sector, the same person comes to you again and again, and over the years you start building up a rapport, and you hear patients tell, you saw my daughter, you saw my granddaughter, and now you are seeing my great granddaughter. Although it brings your age to you, still it is a very satisfying experience, which I think that most seniors will agree with this. From the learning point of view, after I joined the non-institutional setup, it was very satisfying because I could attend many CMEs and conferences and update my clinical knowledge and give a better care to the patients who came to me. In this timeline, the most difficult thing was when I was suddenly sent to Karaikal, where I joined there as the head of the department of pediatrics. Very, very, when you hear it, it sounds so glorifying, but actually there were only 2 other doctors posted with me, and one doctor was on duty, the other was on post-duty off, and I was the sole doctor to manage the OPD when I was not on duty. So much for being the head of the department. It used to be a rush and catch the early morning bus in Pondicherry, rush to the OPD and see a crowd of 150 or so in a half asleep stage. This went on for some time, when suddenly I decided to quit due to family constraints, and quit my job after 20 years on voluntary retirement. That moment was, I think, it will be a devastating moment for any doctor who quits. To be the head of the department at one moment, and the next moment be nobody or just an ordinary doctor. At this junction, I must mention Dr. Nallam, who lent me a helping hand from the abyss and gave me the job of visiting his nursing home and seeing the newborn and other pediatric cases. And likewise, I joined also St. Joseph of Cluny Hospital, and over the years, I was able to achieve what I wanted in life. Of course, I got recognition. My work-life balance was the same in both fields. And here also, both were satisfying, but here also I had to cope up with all the tensions of everyday life. In my patient care experiences, I found out in the non-institutional sector that it was very important to have a rapport with the neighboring great institutions. And for me, many seniors and many of my close friends helped me. So for any budding doctor, this is a must, to have a good rapport. And these rapports come with frequent visits and also attending CMEs and conferences where you get in touch with all these greats. In my case, people who helped me out were Dr. Srinivasan, Dr. Nalini, Dr. Mahadevan, Dr. Bhatt, and of course, Dr. Tirumurugan and Dr. Palniraman. I used to discuss my cases with them, and people in Jitmar used to tell, you can try this. But in any case, if you feel that you cannot manage, you send it to us, we will see. That sort of advice and help put the onus of responsibility on me to treat the children in a methodical and rational manner and not write whatever you feel like. I also learned that in non-institutional practice, self-medication was a problem. And I had to battle that also. In most of the prescriptions, I used to document the findings on the left side with all the prescriptions on the right side. One day, one patient came and told me, your medicine is not working at all. And then she told me, I said, what? How did this happen? And then she said that she comes from an apartment where 5 families live and they all have children and that they're all my patients. And one child or other was sick all the time. And they used to pool the prescriptions. And they'll say, oh, she has written URTA and she has written cold, cough at night. This is what she has prescribed. So you give this, your child is the same age as mine. And they used to give that medicine. And when it didn't work, they used to come and ask me, what have you written for us? So that put a lot of responsibility on me. And I used to write in the prescription, use only when necessary, not to be repeated. These were words which I used to write when I was writing antibiotics and other drugs to safeguard me against all these events which may occur to deter your practice. In a similar manner, I found out that you have to be very explicit and specific when you write the prescription. The prescription that you write is a document. It's not some paper that you scribble some drug on. You have to write legitimately, you have to write in capital letters, and there should be no ambiguity about the time of intake of drug, how many days to drug, and what to do after that. For example, I found that people miss out on the points. If you take paracetamol drops, it comes as 100 milligrams in 1 ml. And if you are going to write 0.5 ml thrice a day, if you miss out on the dot, you have to write 0.5 ml. And if you miss out on that dot, you will end up giving 5 ml thrice daily to a baby of 6 months old. And all of us know the consequences of giving too much of paracetamol. In New Medical Center where I worked, we don't stock paracetamol drops. We stock only syrups, and that too mostly the 120 milligram per 5 ml variety, so that people are able to get only the proper dosage. Similarly, I found that when I was writing drugs like promethazine and ondansetron, people used to buy them and continue using them for days. Today he vomited, so I have given another dose. Yesterday he vomited thrice, so I have given it 3 times a day. So to prevent all that, I used to write only in tablets and only for 1 or 2 days, and I used to write not to be repeated. So these things gave me a sense of responsibility. Finally, I think I am overshooting my time. But there were satisfying experiences in both the fields, in the institutional side as well as in the non-institutional side. But Panacea or Pandora, if you ask me, today in the government setup, the pay, the pension are all very satisfying, attractive, and lucrative. And I will advise any budding doctor who comes out to first try the government side. And if only you are not satisfied with what you are getting out of it, then try other options, because it appears as if the grass is greener on the other side, but at close quarters it is not so. Everything has got its own limitation, and one should also know one's own limitations. Thank you for the opportunity.
Thank you, ma'am, Chidambaram ma'am, for your wise words of wisdom, ma'am. And I would definitely say that with all our, yes, sir, with your wise words of wisdom is of utmost importance for all the budding pediatricians who are there in the forum, ma'am.
Thank you
You have
so
given
much.
a, yes, ma'am. Like it, the words are like some words of blessing for us as well as other juniors, ma'am. This dilemma of taking which path is always there for all the pediatricians. Where to stop, where to consolidate. So, thank you, ma'am, for your speech. It was really helpful, ma'am.
Thank you.
Mahadevan sir, Srinivasan sir, நீங்க ஏதாவது சொல்லணும்ன்றீங்களா சார்?
You want me to tell something? Yeah.
Yes sir, definitely. நீங்களாம் உங்களோட contemporaries and
Oh,
long time.
yeah, as she mentioned, she joined physiology department after coming from, and then I was fortunate that she became my classmate, and I'm very privileged and proud that she was there, such a talented young lady. And of course, we had a good time. And Nalini was doing MD at that time, so we all had a very good learning experience. And of course, she has already mentioned, and she gave a very good talk of her experience, especially in neonatology. She was looking after single-handedly so many deliveries in maternity hospital, and she was efficiently doing it. And I have seen that there also. So she is also established a nursing home along with her brother, and people have very good regards for her and the way she takes care of her children. And she did a wonderful job in private practice and earned a very good name. And she was known in almost every house where there were children. So all the best. Very good talk, Dr. Chidambaram.
Mahadevan sir, நீங்க ஏதாவது சொல்றீங்களா சார்?
Okay, thank you, and wish you all a happy new year. And I think Professor Chidambaram, she's, you call her such a steady and I won't say slow, but she's her words, once you hear her, you automatically feel soothed, and I think that is her strength. And that kind of a communication skill is something which we learned from her. And I think this is the 51st year of my entry, our batch 69 batch entry into JIPMER. And as she said, we had the experience of both the GH as well as JIPMER. She brought out three important points. For a pediatrician, for anesthesiologist, and for an obstetrician, the time is not yours. You can get called at any time, and you have always to be on the run. And I think this does not just stop with your superannuation or anything. So time is not yours. That is one point which she said. The second one is the environment touches you. Yes, she said, your own experience is your own truth. So find it out, but maybe through certain words which come from them, you will also find that you may also have to go through this same cycle. Most important is her attention to details. See, especially what she said about this paracetamol and these drops and other things. I think this small attention is important, because if you look into certain Harvard papers, they would say that 50% of errors in a hospital occur due to medication errors, or it is due to wrong dosages. And I think she brought out that point so well. And in a changing society, which is becoming very litigant, and I think communication, documentation, she brought it up. So it has been going to the past memories. Thank you very much, Dr. Chidambaram, for sharing your thing with us.
Thank you, sir. I think we'll move on to the next topic. No questions is on.
Yes, sir. Yeah, I take this opportunity to, it's a privilege and a pride for me to introduce my teacher, Mahadevan sir, for the next topic. So a few words about sir, I would like to say from my heart before we hear the words of wisdom from sir. Like Mahadevan sir, Srinivasan sir, but sir, Biswal sir have been teacher from the way we were baby students from first year. So the word that for Mahadevan sir has been from like initially it has been for all undergraduates it is of fear and respect, and as we grow a little older and older, it has turned more into a respect and something like a fatherly figure I see now. As a kid, we see that we don't find the reasons why they say all those things. But as we grow up, I definitely find so much. As I think back of the days I have been in Jupar, every word I've heard from all my teachers have been like gold. Um, uh, and I can relate it as I teach to undergraduates. Something I would like to specify from Sir. Sir always insisted on remembering a patient by heart. If I see a patient, I should know the history, examination, clinical findings, and postgraduates in a busy schedule. But then now I really value the way he has groomed us in that way. So it gives a holistic picture from a treating pediatrician. So I would really like to thank sir for grooming us in that way. And there are a lot of words I would like to say about sir, but for constraint of time, I would like sir to start the presentation. Thank you, sir.
Thank you, Elamartin, for your kind words. Thank you.
Yeah, next round. Not
So, a very good morning, and Dr. Bhaskar, the past president of IAP Viluppuram Pondicherry chapter, Dr. Shanmuganathan, the current president, Dr. Ravichandran, the president-elect, Secretary Dr. Ilamaran, and the treasurer Dr. Vinod Kumar, and of course, the energetic Dr. Thirumurugan. Thank you indeed for this opportunity to share this platform at the start of the year when we are transiting in a joyful and probably a peaceful way from 2020. Of course, to share this screen, to be with seniors, Professor Srinivasan, Professor Nalini, Professor Chidambaram, and I think Dr. Vishnu Bhatt is also must be here, my colleague. Thank you very much for being with us. The topic for discussion or for this CME program is envenomation, and I call them as voiceless victims because if suppose somebody comes with probably an unstable angina and then they go and then get treated, by the time they leave the hospital, they will only also ask for, so if you have had this lab here, if you had this cath lab here, so many things can be done, and immediately things get sanctioned for them. Whereas when it comes to children, they are, after all, a very small bed, very small space is required. And sometimes when they come and then they die silently, these victims of envenomation never even come near the screen. So this particular topic, I have certain specific learning objectives for the students who have logged in today. is to identify the clinical presentations and to have standard guidelines. And I think this year 2020, which has been year of science, has also talked to us about guidelines for a number of things. So this will be, I have no conflict of interest in this particular interaction with you. In the next 30 minutes or so, I would take you through these points. Is it really a problem? Is it a problem of, well, it has been a lifelong problem. It has been an age-long problem. So we would talk to you about the burden. And number two is when we have guidelines, it focuses on very specific way of going through a treatment. So evolution of guidelines. And approach. The approaches keep changing depending upon what is available, depending upon the technology, and depending upon the available resources. So it is called IQR approach: identify, quantify, and rectify. And of course, the clinical profile. We are primarily initiated. Patients come to us to be talked to be inquired, then to be examined, and then only to be given the tests. So the clinical profile is first, but at the same time, I cannot say that investigations are not important. They're equally important. But then the clinical profile, once we understand what the mind does not know, the eye cannot see. And then we go on to specific treatment, which should be cost effective, but at the same time should also have an evidence of proof that it is good. And last not but the least, but probably this is the most important, how to prevent it. 2.8 million people have been bitten by snake all over the world. So this is a global emergency. And if 5 million bites every year, there are nearly 100,000 deaths per year. But in India, the mortality rate is somewhere around 14%. Why figures? Every time we talk about figures, is it necessary to document? Yes. Unless we are factful, policymakers cannot allocate resources. They cannot know how much to give. And so very important is we have to be very factual. And this factualness is just not just for getting some funds. The factualness has to be to understand the real burden, to understand the trend of a particular problem. Now, do all countries have snakebite innovation data? Yes, data is important. And this global burden of snakebite is being periodically done, as we are now doing it for the corona. And of course, with certain areas with slightly a gray literature, but now this has improved over time as we see the importance of collecting correct data. People say it is a neglected medical condition. I think if you look into the editorial of Lancet 10 years back, among the neglected tropical diseases and also among the neglected medical conditions, snakebite, because they will just not attribute it, they will give it some other label, and then they say it had happened because of snakebite. And snakebite is observed in all age groups, and majority is between 11 to 50 years, because this is the place where people are very active and there's an exploring nature for the children as well as for the adults. Now, if we look at the peak ages, and it's exactly in the monsoon months and in places which have now turned out to be concrete jungles, as we are building more and more into the available land space, these also migrate. They are also like migrant workers who come to another place to stay. So definitely, I think snakebite mortality is there. Among that, the highest state is in Andhra Pradesh. And of course, you have the figures which are available everywhere. And in Tamil Nadu also, we do have figures which is somewhere around 5.1 to 6.5 per 100,000. And Tamil Nadu is something very peculiar because the Irula community, which is the ones who are basically providing the anti-venom, the material for the anti-venom, they are in the Mahabalipuram region. And I think this is where that snake park, which is in Vandalur, has become a very important thing for us. And so definitely we are contributing in a large way to this national as well as a global problem. So now, if we look at the IQR approach, now that we have understood that this is really a problem with a burden, the snake envenomation went through a number of protocols, because everything was very empiric. And if one is good, the two must be better and three must be best. So people started pumping in so much of anti-snake venom that either the patient died or the patient recovered. And also he developed immune complex nephritis later on. So what had happened is so much of budget of a hospital went on to just procure anti-snake venom, and we were never knowing whether this is the correct dose in the correct time. And this is where I think the National Snakebite Protocol consultation meeting, which the Ministry of Health along with ICMR started in August 2007. And subsequently, a lot of interest came up in Southeast Asia office. And so 2016, you had again a revised thing. And now 2017 document is the latest one, in which both the document contains the guidelines both for adults as well as children. So this is the genesis of the guidelines, in which the Snakebite Research Initiative, which was started in by David Worrell, he had come for that initial meeting at Angamali in Kerala, and subsequently in the ministry, and then it went all around. So this is the first document which came on snakebite identification, the first aid and treatment. And because today's CME is on office practice, I think this particular component of first aid and this thing becomes very important. And of course, things have to change. I mean, we have to keep on reviewing whether whatever we have been doing has consolidated, and we cannot just keep on latching on to the old. So is there any need for a change, for a new guideline? And that is what has come in 2017, the standard treatment guidelines. Now we talk about Oxford vaccines and everything for Corona. And remember, I think this goodness and sharing of wisdom from Dr. Ian Simpson from Oxford University was a turning point for us at JIPMER, where we worked, and he had been a source of energy for this initial meeting. And of course, with so much of work done by the Snakebite Research Group, ultimately it went on to what is called an Afro-Asian protocol. And in Asia, I think the Pakistan Medical Research Council also agreed upon it, probably the only time when we were united on some protocol. So and right now it is the Africa. So the most important thing, if you look into the Indian journal, Indian Pediatrics, do it right. And I think this slogan was from Dr. Ian Simpson. Right, reassure the patient, immobilize the same way as you would for a fractured limb, get to the hospital immediately, and tell the doctor of any systemic symptoms. And I think this slogan is the most important, I would say, Taraka Mandram or something like that for this thing. So it is a first aid treatment. We should not, I'll also show you what is first no aid treatment in another slide. Most important thing is transport. I think transport is very critical, which we realize this is the conventional transport, which we still see in places. It doesn't mean that things have not improved. Yes, definitely now is 108. And even the story of origin of 108 was due to a snake bite. A worker, a British worker who was in the Bayer's Pharmaceuticals in Hyderabad, got bitten by a snake during one of her evening walks in her in her establishment garden. And she got bitten by a snake, and she had to be moved to the nearest government facility, the government nearest center. When she went to a corporate center there, they just said, no, we don't treat snake bite because if she dies, the postmortem will be done only by the government doctor. So please take her further. And by the time she reached a government facility, she died. And this led everybody to take it up to the highest thing at that point. Late Dr. Rajshekar Reddy was the Chief Minister of Andhra Pradesh. And with our Honorable President Dr. APJ Abdul Kalam, they realized, but probably life is time and transport is something very important. And that is how the 108 came, and all the protocols for snake bite got come, because this was a foreigner's death in our land, and definitely things had changed so much after this 108 had come into the Indian screen. So the most important thing is do it right. You have to immobilize as you would for pressure immobilization. Now, and you can see that splint which is put here, because if a patient is going to keep on shaking his hand that I am got bitten here, and he just does what is called a snake walk to the nearest center, definitely whatever are the molecules which are there, they get pumped by the muscle into the systemic circulation, and he is going to get envenomed faster. And some people get faster envenomation, some later. This may depend upon the molecular weight of the proteins which are present in the venom. The venom is nothing but it's a cocktail. It is a cocktail of proteins, and the speed with which it goes will depend upon the mobility. And that is where I think in the first aid, most important thing is you have to put pressure, but not pressure so tight that the circulation gets obstructed. So this has to be a pressure without immobilization. This was done in Australia, and a number of doctors have been trained on these things, and still people do it. Now, important thing is 70% of snake bites are from non-venomous species. Only 50% are from venomous species. They really envenom them. So we have to reassure the patient, because Pamba Kanda Padayun Nadungon, they will say. So it is a question of the reassurance, which is what is important. Number two, immobilize the patient as is done for a fractured limb. The rationale is, of course, for children, we can carry them and see to it that they don't move it. But adults, the bandages or cloth should be used to hold the splints in place and not to block the blood supply or apply pressure. Use of tight ligatures to apply any kind of compression is a danger, and they do not work. Get to the hospital immediately. In fact, there had been even some TV serials which just said that if you keep the patient awake throughout the night by making some songs or something like that, the venom would go away from the body. Maybe some of them got better because they were non-venomous snakes, or maybe, but majority of them get to the hospital immediately, GH. So the rationale is there is no proven benefit in the treatment of snake bite with the use of traditional remedies. T. Telltale signs. The doctor should be told about any small signs which they have noticed as they come, such as ptosis that may manifest on the way to hospital. Because sometimes in the evenings, when some of the people come and wait in a health center, and then they may have ptosis really after work in the getting bitten by a thing, but then they will say, maybe that is why this ptosis is there, and they may never be taken care. He goes home, and then again he comes back with a respiratory paralysis. So the important thing is telltale signs help you to prepare the treatment plan. Yes, as I said, first no aid treatment. The pressure immobilization, which is so tight like this tourniquet. And if this particular snake stone, I have seen it in a center which is just 10 kilometers from Jipmer. In this center, they will take this black stone and then ask the patient to go and buy milk from the nearby booth and come, and then put the thing on the wound, and then take the stone and then put it into the milk, and if the milk turns blue, they say it is poisonous, otherwise it is non-poisonous. So you understand that there is a lot of myths and beliefs which surround the snake bite. And of course, in Rajasthan, more punki, because as Dr. Srinivasan had said, Ilamaran, I mean, Lord Muruga. So Lord Muruga is more travel. So they tend to put this kind of a tourniquet with or some alum, or they go for some praying. So I understand, we don't question their culture. But what I'm saying is, time is like golden hours do not exist only for coronary syndromes. They exist for almost all conditions. And of course, this is a Bollywood way of treating, giving first aid. Cut it, suck it, and then put the tupata around it, and then send it off. So these are all not inapplicable snake bite first aid. Now we'll go to the next point, that is the IQR. Okay, once the snake is, sometimes they kill the snake and then they bring it. And by looking at the snake, sometimes we are able to say, okay, this is a viper, this is a cobra, or this is a sea snake. And so herpetologists have come out with a lot of books, and even the things in the snake park in Chennai, they have put good books in which we can be able to identify the snake. Or we'll have to identify the symptoms as doctors. Then we quantify for the coagulation profile. And then we have to rectify only with anti-snake. Of course, so many of snakes, just like so many snakes which are available. But the most important thing is once a patient is treated with snake bite, he recovers fine. The story does not end there. But after that, you will find that the necrosis which it has produced, the amount of sort of a challenging to his own mobility which it has produced, he will then come under orthopedically challenged person. I mean, this is the foot of a person who got treated and who came to give his wedding invitation after a number of years. So you can understand this has happened, but then they have learned to live with it. But again, this could be prevented. And of course, they used to say there are big fours, but now there are also some more snakes which have been identified, especially the hump-nosed pit viper, which is in the backwaters of Kerala. And some of these do not respond to our conventional anti-snake. So when you come with a non-critical arrival, when were you bitten? What were you doing? And what first aid is given? I think this is all important questions to be asked. Not that you waste a lot of time in questioning them. You just have one look and then you know what. Now, initially, I think about snake bite, we were taught only in the forensic medicine classes. There, they used to say, if you have 2 marks, then it is venomous. If there are multiple marks, it is non-venomous. No, I think such kind of a conclusion about bite marks is very inconclusive, because if you can even see here that you find that this type of fang which the snake has cannot make this conclusion right. And especially some of these snakes in Rajasthan, kukri snakes and few other things, they have a different type of venom configuration. Then tourniquet removal has to be done, and you have to keep observing for late onset envenoming. And a 24-hour observation is better. It is better to over-admit patients rather than send them away, and they will come back with cervical pantumati, they will come back again with respiratory paralysis. So this observation is important. And for pain, of course, no aspirin, because we know about. Now, snake identification, the fang marks may not be visible. The bite site may not be painful. So very important thing is we have to do it right when it really matters. And this is the girl for whom it could have been a bad morning with just, I think here, at night she had bitten. Morning she complained of some abdominal pain. And by the time she reached the hospital, she was having a respiratory difficulty. And because we know that crate is notorious for making this kind of a thing, and this is where I think fang marks may not be visible, the bite site may not be painful. And this was the girl who recovered from crate bite. So presentation, our concern is asymptomatic or symptomatic, whether it is going to be critical or non-critical. High index of suspicion should be maintained. Now the other group which comes with ptosis, with a swelling and with a neck flop. And again, here you can see the ptosis, which is due to the Russell's viper. So both neuroparalysis also can occur with Russell's viper, though we know that hematological is what is seen, that you have bleeding manifestations, student going across for a tuition and then coming back in the highway, got bitten by a snake, and then he comes with this swelling. So the important thing is this 20 minutes full blood clotting time. Does his blood coagulate or not? So this 20 minutes full blood clotting time, most important thing is with what you do it, a clean, dry test tube. It requires 2 ml of fresh venous blood, and incoagulable blood is an undisputed diagnostic of a viper bite in India, and certainly removes any doubt of an elaborate bite. So we do what is called a syndromic identification. Hemotoxic viper, neurotoxic great cobra, Russell's viper, and we find that acute kidney injuries is most often seen with Russell's viper and hump-nosed pit viper. Most important thing is sometimes we think that they have some gum bleeds, certain other things. These are all due to certain molecules in the venom. In fact, this, as I said, it's a cocktail of proteins, and it also makes every receptor in the body it gets affected. So you have what is called the neurotoxins, and which inhibits acetylcholine release from the presynaptic vesicles, and postsynaptic is for cobra venom, and metalloproteinases activation of factor 10, and these are all activators of the prothrombin. So these are all the bases on which you get abnormal coagulation tests. spontaneous systemic bleeding after viper bite. You can see where all, especially the gum bleeding, and especially sometimes in the morning after the villagers go for an ablution, they also come back with snake bite. So this is very clear about this postsynaptic vehicle. It is nothing but an inhibition, the acetylcholine in the vesicles, and then this is the venom goes and occupies these things. So it's a postsynaptic envenoming. Whereas in a crate, it is the complete destruction of all the vesicles. So as a result, it is going to take time for these vesicles to regenerate. So in a presynaptic crate, you may have to wait for the entire neurotoxicity to come back to normalcy. So when any case comes, we look at, is a possible bite? Yes, he is asymptomatic and he has got normal coagulation tests. Remove the pressure bandage and observe for 4 hours if he is well. Sometimes you can even keep him for 12 hours, depending upon the clinical condition. The next important thing is this human clotting cascade is something, it straight away does this procoagulant, affects these factors, and then you go in for the venom-induced coagulopathy. Now remember, this is a dynamic picture which evolves. Within 1 hour, you will get all these symptoms. That is the idea of keeping them under observation. No, headache, okay, paracetamol, and then transient hypoxia, I don't know. What is important is this observation over this 1 hour, a hand on the pulse and a look at the patient. And I think it is this clinical examination which is going to make us look at the evolution of symptoms. 1 to 3 hours, it will go in for a paralysis. That is why somebody said, if somebody has got a facial as well as a brachial and also bulbar paralysis, think of snake bite unless proved otherwise. Just like as we say, some child comes with a priapism and then sweating, it is scorpion sting. Here, this is the snake bite. And after 3 hours, you get, so everything goes on with what is called a legendary speed with which these molecules travel and then occupy all these receptors and produce this. And you can also get dark urine or acute renal failure also acutely, and see more north and also in Madurai area, this used to be a very common. So rapid illness develops after multiple bites in a small child. So we went through what is called, initially we talked about a possible bite. Now we are coming to a definite bite. Mild symptoms, abnormal coagulation times. Then remove the pressure bandage, observe for 12 hours if well. And again, always inform ICU about any patient can come in to it. Don't think emergency and ICU are nothing but 2 doors. 1 door revolves it together. There is nothing that this is one unit and that unit is something separate. This kind of a compartmentalization is what causes a delay. So, and I think in the practice, we need to look at such delays are obviously avoided. Now, if we look at certain simple diagnostic methods, we find 20 minutes whole blood clotting time is the false positive in a non-envenomed patient and suggesting a high specificity. Important, what is this 20 minute? Clotting time is not 20 minutes, but important thing is you give the body so much time that if it has to clot, it should have done at least by 20 minutes. If it has not done, definitely this is an abnormal bleeding. Number 2 is progressive weakness, which is called a single breath count, or the length of time an upward gaze can be maintained in a patient, or basic grip tests. I think these things by which you can find out that the neurotoxicity is evolving or is worsening. The next important thing is painful progressive swelling of the limb, measurement of the circumference of the limb. And the simple measurement is sometimes important because it rapidly crosses the joint. Definitely, it is important. So you have a patient who is possible, or you have a patient who is definite, but symptoms are not much evolved, or you may come with a very ill patient who comes straight away to your to your practice with hypertension, bleeding, paralysis. And leave the bandage on because ASV supplies, once they are insured, then after that you can take the bandage out, because removing the bandage only when a patient is stable. Sometimes we find that you will find that suddenly removing the patient may cause a gush of the venom which is accumulated proximally to go into the circulation and the patient will worsen. So remove the bandage only when he is stable, and always have an adrenaline pre-medication before the first dose of antibiotic. So critical arrival, I don't have to again stress on these things. And the important thing is you need to have a straight away an access. It is not that the moment a patient like that comes, it is not that immediately he has to go. Whatever has to be done at your primary level has to go. The venom has to, at least these are the primary things which we need to do. Establish large bore IV access, and test for the presence of pulse distal to the tourniquet. If pulse is absent, ensure a doctor is present before removal of the ligatures. In case of clinically confirmed venomous bites, remove the tourniquet only after starting loading dose of ASV and keep adrenaline injection ready. And carry out a simple medical assessment, including history and this thing exact on record. So very important thing is clinical examination and recording of findings. But remember that this is the minimum thing which we can do, though you may not be able to treat it completely because of your own difficulties. I think one doctor said, sir, if we give this ASV and all these things here, and tomorrow something happens, there will be a roadblock between the hospital and this thing. But it doesn't prevent us from at least attending to the important things, which is, okay, this is a common scene in which a patient comes for it. And of course, now algorithms are important, because once you put algorithms in your own unit, you'll be able to see them and see where he or the child falls into, whether it is painful progressive swelling, viper, neuroparalytic cobra, vasculotoxic is saw scale, and myotoxic is flat-scaled sea snake. So you have the treatment which is available, and main treatment is supportive ASV or supportive and then transfusions. So I'll go through rapidly these things, because it is nothing but a syndromic identification in which we talked about cobra, crate, and viper. Even when symptoms have persisted for several days in hemostatic, the ASV may reverse systemic envenomation. Symptoms require it is appropriate to give ASV. Local symptoms are very important. And the Glasgow Coma Scale cannot be used to assess the level of consciousness of patients paralyzed by neurotoxic. So we have all these clues which are present to identify that this is definitely an. I look for two important things. One is the tender lymphadenopathy, number one. Number two, pain in the renal angle. If you have pain in the renal angle, especially to remember that these are the patients who can go in for an acute kidney failure fast. And clinical features like time lag and reverse order, in which this is how it takes for the recovery to take place. And you do have everything available in a primary center. And of course, people say neostigmine can be given along with it. But neostigmine is only a test. It is to say whether the prolonging the life of acetylcholine, which is present, and if there is no response beyond 2 hours, I think we should stop that. Now, ASV dosage. Now, what to give, we are very clear. How to give it, and what is this ASV dosage? It is found that for the amount of venom which is done, this Myanmar scientist who found it, that around for this neutralizes roughly so much of venom, and 10 vials in 1 hour at a steady rate. This is important. And there is no test dose, because test dose can only find out anaphylactic because it is IgE mediated. But here it is complement mediated. So the test dose is of no use. So it is only an anaphylactoid reaction which we need to understand. So this anti-snake venom is available in 2 ways. One is lyophilized as well as liquid, and depending on the advantages, depending on the shelf life and requiring a cold chain is what is. And when to give ASV? When you have 20 minutes whole blood clotting time abnormal, you have a current systemic bleeding, and you have neurotoxic signs. Severe current local swelling, half the bitten in the absence of a tube, and rapidly crossing. These are strong indications for ASV. And ASV in the children as well as in adults, it is the same, because the snakes inject the same amount of venom into adults and children. But why no test dose? As I told you, it is usually not IgE mediated, but complement activated. And these may pre-sensitize the patient and create a greater risk. Very important. And I think this is where I think I found that the steady, slow and steady kind of an approach, which is important, which I think we had seen. Symptomatology is of no help to determine the severity of envenomation, as it is constantly evolving. The initial dose is 8 to 10 vials. The reconstituted vial in normal saline or 5% dextrose has to run slowly over 1 hour or even 120 minutes, because we lost a child because somebody said, okay, why not neutralize the venom very fast, and they ran it as if they were giving a 10 ml per kg bolus. And once the infusion went in like that, the patient went in for a severe protein shock, because these immunoglobulins produce a protein shock, and after that whatever we do was only a last minute trauma. So very important thing is the slow and steady infusion is something very important. 1 hour at a constant rate with hemodynamic monitoring. And I think I will again and again stress, because we learn a lot of things from a mouse by Googling, but wisdom comes only through our mistakes. Again, repeat dose. Do you think it is again repeated? Yes. Reassessment for unimproving symptoms in hematoxic, 6 hours. In neurotoxic, you have to do it within 1 to 2 hours. And the upper limit for viperine bite had been only 30 vials. And that too, it was in a mother who had an antepartum hemorrhage, and then she was bitten by a snake. And of course, in neurotoxic, more than 20 vials will not be of any value. So a timeline-based approach, we need to have this. So of course, these are some patients who are on ventilator and then who are extubated because of later. And we should also know what is called the locked-in syndrome. Now, more important than this, it is a question of ASV being given, and you look at their reaction. This is what everybody is afraid of. Suppose, in fact, at one point, people were afraid of benzoyl penicillin because of it produces reaction. So everything went in for then a oral penicillin, and oral penicillin was as good as probably no penicillin at all. So reaction treatment, the first sign or symptom, you need to look at, expose the chest. In fact, the first sign of a rash comes in the chest. Then after that, the body comes. So you will find here, and you have to give adrenaline IM, because we were more used to giving subcutaneous. But remember, in subcutaneous, the plasma time is 34 minutes. In IM, it is 8 minutes. And also with the steroid support. So this was the study from Sri Lanka, which said that initially having a steroid support may be of use, maybe hydrocortisone takes 4 hours, but adrenaline is very important. And this is something like we should not be afraid. If this thing happens, okay, stop the drip. And then after that, again, start continuing the drip in a steady and slow manner. This is something like a pit stop, which we do in a formula race. In formula race, if something goes wrong with the wheel, it is not that they stop the race further. They come out, pit, get everything arranged fast, and then they continue their job. I think ASV giving is something similar to that. Because the reaction has come, we should not stop. It is not a question of a fear of the unknown, or no, it is not a question of once bitten, twice shy. We have to continue, because ASV is the only treatment, and give it in a steady manner under monitoring. ASV, when not to give, when there is no local progressive swelling, isolated thrombocytopenia does not warrant it. Just to treat renal failure, no, and late recovery from a ventilator, especially in a crate bite, and ASV is of no use after 4 days. Complications, surgeons, they come to us, especially some of them come with this kind of a picture also. And there's a pain on passive stretching, pain out of proportion, pulselessness, pallor, paresthesia, and paralysis. You have what is called the compartment syndrome, the fasciotomy has to be done. And local tissue necrosis, secondary. This is where I think our plastic surgeons come to our great help. What requires is only a time, patience, and regular dressing. So the recovery time is what is we are seeing. Spontaneous systemic bleeding stops in 15 to 30 minutes when you give ASV. Coagulability is restored every 6 hours. Why the 6 hours is the liver takes 6 hours for the factors to be regenerated. Then we have post-synaptic type, in which 30 minutes after the venom, it can, in cobra, they recover very fast. Whereas in crate, it may take a longer time to improve. And even it has taken a week when patients has been on ventilator. And then they have come out of it. And shock the patient, sometimes we find within starting 30 to 60 minutes, their shock also improves. So these are the timelines which we should remember for that. And of course, a long hospital stay. And then with this grafting patient has improved. So and severity of envenomation. This is where I think school health programs can tell children how to handle a first aid after snake bite, because you say everywhere, every school has got a garden. So definitely it is not that we are going to be free of snakes. We have to learn to live with them, but at least we know how to go about because this is an important factor. Patients running after a bite increases the rate of absorption. Then the nature of first aid given and time elapsed before the first dose of venom. Availability of inter-hospital transport services is very important. And of course, this is a JIPMER experience in which we had looked at the younger age, walking for more than 1 kilometer. These are the things which affected the outcome. And of course, in 2016, another similar study came from Calicut Medical College, a very nice, good, important study, which also talks about all these factors as the risk factors for a poor outcome. Because the important thing is people keep asking you, okay, will this patient be all right or not? So based on such evidences only, you can give them some sort of facts or educated guesses, we can say. Now we have what is called the locked-in syndrome, which can happen in crate. And it is a neurological, which is defined by sustained eye-opening, preserved awareness, aphonia, quadriplegia, and there are 3 types, which is classic, incomplete, or total. So these are for finding it out. And remember, it is this kind of a brain dead state. People were about to give it up, but then the PICU with ventilator support. I remember this was the one student called with us, MD student Neha Bataria, when she went to Delhi, and I think she communicated with us in which, you know, this giving ASV, not losing hope, especially in this locked-in syndrome health. So most important thing is this was how PHCs were at one particular point of time, where they were even doing cesarean section in Ramanathapuram things. But now I think with the litigant society, that is, but then at least when you transport a patient, you can transport him with airway protected, especially in crate, because many of the crates, when they reach the hospital, they are already paralyzed, respiratory paralysis is already set in. So important thing is this would be asking for the ideal. It was there, and it all depends upon the way in which things are taken. 20 minutes. So how snake bite can be avoided? Education, know your local snakes, the sort of place they live in. Be especially vigilant about snakes after rains, flooding, and at harvest time. Try to wear proper shoes and long trousers. Wearing shoes is not for fashion, especially even in JIPMER campus, or even in front of it, a very senior surgeon, when he was coming for a walk in the AAR quarters and JIPMER quarters, he got bitten by a snake. So what is important is wherever you walk, use a light, and that is very important. And this is what, you know, village people, whenever they walk in dark, they always carry, they always carry with them. So how snake bite can be avoided. And avoid snakes, handle threatened, affected snake. Keep young children away from snake infested areas. Check for school benches after vacation. Check socks, pillows, and sleeping mat. This also applies for scorpio. And avoid rubbish, thatched roof. They can fall from the roof. So these are some risk activities which can produce this thing, especially cutting the grass, carrying like this. So you understand these are all occupational hazards. Of course, now with a lot of Swachh Bharat, I think this is lesser ring, but then this is again a risk factor. Corona or snake, both do not discriminate. We are all in this together, and as a result, now we have found whatever are the supportive things which are required for Corona. I think we have been doing it earlier for snake in a different way. So, but I think we need to continue this. And for prevention, of course, this is malaria. They will put a net and other things, and at least don't sleep on the ground. Sources, very important thing is this information should be available, because you may not always remember certain things. When lawyers can have so many law books and refer it whenever they want it, we also have to have some source of information, and these are the two sources. So let me going to conclude saying that protocol guided treatment is very important. ASV should be administered at a constant rate of infusion, allocating resources in a primary health center, and enhancing the confidence. Now our confidence levels to handle Corona has improved over years. At one point, people were even afraid to go nearby. In fact, I still remember there were people who were even afraid to see rabies cases when they came to the casualty in GH in those days. So as a result, now our confidence level has increased, because now emergency management has now become the order of the day, thanks to Corona. And sports medical treatment and new knowledge means definitely there is going to be a change in practice. I am going to leave you for your lunch, probably thinking that life is like a pizza. Pizza confuses us. It comes in a square box. When you open it, it is round. And when you start eating it, it is triangular. And these voiceless victims of envenomation are also sometimes like pizza. If you understand the way they present, the way in which they have to be handled, they look different, they appear different, and they behave absolutely different. But I think persistence in our protocols, things will do a lot for them. Thank you very much for your time and patience.
Thank you, sir. Sir, Dr. Nalini madam has asked one question. Do we have species-specific antivenom in India, and do we have monoclonal antivenom?
Yes, I think this polyvalent is what is available. This species-specific antivenom is costly. That is one. Of course, Australia has got this species-specific antivenom, and I think Amrita Institute was trying to come out with species, but what was standing between the patient and the policymakers is the cost, which is there. We don't have it. But people can always say, I can get it from Singapore, because if you have to have the species, you must, that's an ELISA test which Dr. Eapen of, say, Anganwadi, he developed. but I think it did not come in a big way. And there's only one Singapore person, I think he was a professor of biochemistry in MMC. He had developed that kind of a kit by which he can identify the species. But then again, what it is cost. Or if things can be worked out slowly, I think that can also be overcome and we can come with a very specific diagnosis.
Thank you, sir. There are no other questions. Anybody else wants to comment or say any questions on? Srinivas sir, Nalini madam, but sir.
Yeah, his lifelong mission in snake venom and scorpion venom, besides developmental pediatrics, done justice to the talk. And of course, as Nalini madam has asked, we don't know here most of the times what type of snake. So it has to, polyvenom is more important in saving these children. So most of the times the snake is not there and it's impossible to find out what type of snake has bitten and what is the venom. And monoclonal antibody may not be realistic in Indian situation.
Thank you, sir.
Thank you. Thank
No
you.
other questions, sir. So thank you very much, sir. We'll move on to the next session with Dr. Ilamaran, who is Chitmarite, ex-Chitmarite, and who is currently working as professor of pediatrics at Mahatma Gandhi Medical College. He's very enthusiastic about, and he has published quite a bit of work on typhus, scrub typhus. So he said that he will share his work on scrub typhus in Pondicherry. So I think I'll request Dr. Ilamaran to start because we're really falling behind on our schedule. Thank you.
Thank you, sir. Are you seeing the screen, sir?
Yeah, we're just about to see.
Is the screen visible, sir? Yes, sir.
Yes, sir.
Okay. Thank you, Tarun sir. As the time is short, I will directly go with the talk. Basically, I just wanted to share and sensitize the current scenario. So we'll be speaking about the general profile of undifferentiated tropical fever, what we have, and this is the season for scrub and dengue as well. So I'll be emphasizing on what the consensus guidelines on for the empirical therapy of undifferentiated fevers. And we'll be looking at the clinical spectrum of scrub typhus as well in our region because it has multiple facets. At one time, it used to be syphilis, which comes in different kinds of presentation, and then it used to be HIV. So, and now we have even corona, which is having multiple presentations. Like lately, some patients presenting with mucormycosis following corona. So something like that. Scrub also has various facets which we should be aware of. And the major blockade is the point of care testing. As the point of care testing becomes more readily available, something like a whole blood clotting time, which we can just do it on arrival of a patient at the bedside, we can make a decision. So that makes a difference in clinical management at the primary care physician level. In hospital settings, many a times it is available, but in primary setup, this is what makes many of the patients going undiagnosed. And finally, this is what the recently coming up as antibiotic responsiveness. We have seen that the response to antibiotics is slightly changing compared to the reported literature. So that also I'd like to emphasize today. So just to start with, this was large scale. There are 2 large scale studies done across India in multiple ICUs. This was done from PGH Chandigarh as the leading point. There's another study with Vellore as a leading point, where they have taken 34 ICUs in India, and with a good most of the patients have been quite sick enough that the mortality is at almost 18%. So what they have found is throughout the year, dengue and scrub typhus have been the predominant febrile illnesses which have been affecting the children, especially in the winter, in the rainy seasons. Then comes the meningoencephalitis, malaria, leptospirosis, sepsis, and pneumonia. These are the top things we'll have to consider and work up. And there was a time when meningoencephalitis presentation was almost always Japanese encephalitis, But over the years, as the reports of scrub typhus built up, even in the northeast area and Assam, Bihar area, previously it used to be undiagnosed encephalitis syndrome. So later people realized that it is a scrub typhus. So this is a story which has evolved over the last 20 to 30 years. So this is the recommendation of the critical care medicine guideline consensus. So it is better to have a syndromic approach when it comes to undiagnosed or undifferentiated tropical fevers. So we are all aware dengue and thrombocytopenia is like its layman's terminology. So whenever you come across a patient with a falling platelet count, it need not be just plain definition of thrombocytopenia. Falling platelet count from the previous value, you think of dengue scrub. In our area, malaria is almost, less reported, I would say, or less diagnosed. Leptospirosis is also to be taken into consideration. So in the particular study, thrombocytopenia was seen in almost all patients with dengue, and in 60% of patients with scrub typhus. So, but most often in our experience, we find that many of them come with a respiratory presentation, an undifferentiated fever with some cough and cold, and mild tachypnea and tachycardia. We don't have much lung findings on chest X-ray or on clinical examination, but we have a supportive thrombocytopenia or organomegaly. We strongly think in terms of scrub typhus, malaria, typical and atypical pneumonias. This picture, atypical pneumonia also we think of. So in the setting of renal failure, just azotemia is there, patient is sick looking, think of scrub typhus, leptospirosis, and dengue and malaria, because all this compromise circulation as well. And the common presentation is encephalitis syndrome. In children especially, if we take, then even in our setup, apart from Japanese encephalitis, this is one of the equally important organism, and many setups in Northeast India, this is the most common cause for acute encephalitis syndrome. So much so that there is empirical inclusion of anti-rickettsial medication also in children presenting with encephalitis. I'll come to that later. So then fever and jaundice, most often it is viral hepatitis. Fever and MODS, most often it is sepsis, sometimes scrub. So that is how it is. So when it comes to empirical therapy, again, at the community level, it is better to have this syndromic approach, and as much as possible when we can get the point of care, I'll be talking about the test as well, point of care diagnostic test for dengue, malaria and typhoid, we are almost sure what we are treating most of the times. So the recommendation at that point is ceftriaxone and doxycycline in a child with undifferentiated fever. You have waited enough for 4 to 5 days to 7 days for, let's say, thinking there is nothing at all in the blood counts, nothing at all in the clinical examination, no eschar as well. So it is justified in an endemic area during the rainy seasons to start doxycycline as well. Acyclovir is as by recommendations in a child presenting with encephalopathy. Coming to encephalopathy, we don't have time to wait and watch. So we always have that patient arrival to antibiotic time. So in that, we say that within 30 minutes of arrival in a sepsis child, we'll have to start antibiotics. So ceftriaxone, doxy, and acyclovir in this scenario will be an apt choice, awaiting all the investigations. So just a clue of how to differentiate between dengue and scrub. Many times they come with minimal edema, thrombocytopenia, and hypoalbuminemia is almost always there in both the settings. Transaminase elevation is also there. So till we get our hands on our blood reports, the point of care reports, or in case situations where you really don't have the investigations, this happens in primary care setups where individual doctor is there, they may not have the lab nearby to get the data. So in the absence of a typical eschar, when you get a CBC value itself, a hemoglobin of more than 11 in this study there was a very high chance, 10 times chance that the child was having a dengue, and especially in association with the low leukocyte count. Whereas if the patient is having more of tachypnea, the counts can vary. It can be leukopenia or leukocytosis in scrub, but the patient is having significant tachypnea. The I mean, the weightage tends more in favor of scrub typhus. So there have been a lot of studies done in India and the other countries as well on undifferentiated fevers. So it is almost matching with the Velo data and or local data. Scrub typhus is the most common febrile illness which comes in October to January season. So peaks somewhere around December and January here. So in an undifferentiated fever, it is almost always scrub typhus. You don't have to look out for a typical eschar as well. Many times the eschar is also not there, or it has the scab has fallen off that we cannot recognize it as a eschar. And many a times, because the point of care testing or a scrub typhus testing has not been done, they come to us after 10 to 15 days. So the only clue will be a thrombocytopenia or a multi-organ dysfunction kind of picture which comes. So we are justified in starting doxy in our setup. In our area, so far malaria is less reported. So I'm sure as our present audience is all senior pediatricians and experienced pediatricians, so you definitely would have come across the eschar. And in our study as well, we found that this was the distribution. Almost 80% was in the hidden areas. So it is the routine practice for all the institutional postgraduates as well as doctors to look for, or we call it as comb for eschar. We just undress the child and comb for an eschar across the body, and we encourage parents to examine them as well. So now let's come to the atypical clinical spectrum, because this is where the cases get delayed and there is some confusion over which specialty will take care. Recently, 1 week back also, we had a child with acute abdomen with clinical suspicion of appendicitis, posted for surgery, but then there was no conclusive evidence for appendicitis it was under pediatric surgery or it was under general surgery that pediatricians picked up eschar and we suggested that we do a scrub typhus as well, and scrub typhus test came positive and then the patient was managed conservatively with the doxy alone. So it's very common for them to present as a simple fever with gastroenteritis as well. So even though respiratory is the most common presentation, sometimes they present with the vomiting and diarrhea as well. So cholecystitis has been diagnosed. There are settings where they are presented as viral myocarditis or in adults as acute coronary syndrome as well. In our setup, cerebralitis kind of presentation where the patient presents with ataxia and nystagmus, that has been quite a few cases of CNS manifestations. Cranial palsies are also be well reported. So we should look out for atypical manifestations. So this is the consolidated. I'm sorry if I'm just rushing up because we are falling short of time. So so a lot of patients come with kind of viral hepatitis picture, interstitial pneumonia, and as I said, cholecystitis or gallbladder wall swelling, edematous gallbladder as commonly reported. So it is not to be mistaken as cholecystitis. And this edematous inflamed gallbladder is not specific to dengue. I mean, it's specific to scrub typhus. It is common in dengue as well, in enteric fever as well. Even in undifferentiated viral illnesses, measles also we can get gallbladder swelling. So rarely it is presented as massive lobar pneumonia. So it has been reported in JIPMER, Indira Gandhi, as well as in our setup. Patient presented with bilateral or unilateral lobar pneumonia. So we sort of think that it is a typical lobar pneumonia or atypical lobar pneumonia. But probably an azithromycin for a atypical lobar pneumonia has changed the scenario. But in these three reported cases, as well as in other states where lobar pneumonia picture has been reported, documented ICD positivity or Weyl-Felix text has been there. So in a child who is not responding to typical penicillin antibiotics, anti-penicillin antibiotics, we'll have to think of scrub as well. So these are the other presentation. Myocarditis being reported in Chennai, even as monoarthritis. Again, as I said, in children, the commonest presentation is of commonest meningoencephalitis in many places is scrub typhus. in our place, we most often say Japanese encephalitis, but now we can say with 50-50 hand that it is JE or scrub. So there was a report of bobblehead doll syndrome where child had typically come with nystagmus and titubation, that is head nodding. And investigation ruled out tumors or encephalitis. There was just cerebellar inflammation edema, and the scrub was positive. Child recovered beautifully with medication. So these are all the varied CNS manifestations. Even GPS kind of presentation has been reported. So just to be aware that even in a child with cranial nerve palsy or psychiatric manifestation or even ADEM, to look for an infective etiology, a treatable infective etiology. So, coming to the recent updates with the point of care testing. Like for typhoid, we are trying to. This is the tropical fever is not just a local problem; it is a global problem. So at the level of CDC and WHO, they are trying to find an ideal point of care testing where we can just diagnose typhoid, malaria, dengue, and scrub. So as these are common ones. Previously, IFT used to be the gold standard. Even now, by textbook, it is the gold standard. But then across the world, that is the Southeast Asia and including India, the IgM antibodies for scrub typers has taken precedence because it is easy to do, less costly, and easily available. And among them, there are multiple brands which have come up with IgM ELISA. In our institute, we are following Invios. This is the US brand which is there. And this is one of the study published in India as well as in South Korea about the Invios technique. So as you can see, the sensitivity and specificity pattern for this particular brand was quite high. So for quite some time, we have been using the IgM ELISA card test for scrub typer, and we get the report within 1 hour time. So it is the decision making time is the turnaround time is quite faster when it comes to dengue and scrub. So if this can be implemented or sensitized among the private practitioners by our IAP, so it will go a long way in reducing the burden of the disease. So lastly, this has been there has been just two publications based on the antibiotic responsiveness, that is again from South India. So there is increasing evidence of in Southeast Asia, especially in Thailand, doxycycline resistance has been quite rampant because malaria is also quite rampant, and doxy has been used as a prophylactic medication for all the tourists, military personnel. So there is ample evidence for doxy resistance in Thailand and Indo-China area. But in India, doxy is not being much used. So there is a very good response to doxy. So there is a good fever control with doxy, whereas a poor or a delayed response to azithro. With most antibiotics, we have definite guidelines to say this is a resistance, like a minimal inhibitory concentration of a drug, or we can have a in vitro studies for resistance. But if it comes to scrub typers, as of now, till date, even though a lot of studies are being undertaken, there's no concrete way of telling what constitutes as resistant or a delayed response. And delayed response is not just a drug alone; it is multifactorial. So in our study, after controlling all the variables, we found that doxy definitely has a early advantage, better fever control than azithromycin. There's one more study which says that which reports a similar finding. This is in contrast to the world literature, especially from Thailand. In Thailand, it's exactly the reverse. So among the patients who had a rapid response to antibiotic within 48 hours, there was a significant difference. The children with doxy, only 8% had persistent fever, whereas 25% had persistent fever with azithromycin. So this area, I thought we should focus more and try to see whether it is resistance or just delayed response. So this will be my take-home message for today, so that we should be having a syndromic approach, and as per the consensus guidelines, always think of adding doxycycline in a sick child presenting with encephalitis. So I know it has been a very short talk, so and I kind of rushed up, so but basically I just wanted to finish it faster.
Short is sweet. Short is sweet.
Yes, sir. Thank you, sir.
You covered everything, all important points.
Thank you, Dr. Ilamaran. I think you finished very much on time. Thank you. I mean, Nalini madam has asked for the dose of doxy you use in children.
Yes, ma'am. 4.5 mg per kg we use per day, ma'am, in 2 divided doses. So, and the recent literature has shown that even newborns can be given doxy. So it is only the doxy or the tetracycline toxicity is more specific to the older tetracyclines, and doxy is shown to be useful in newborns as well.
So you write a prescription of doxycycline, it's always associated with so many other things, but it's not available as a single compound. Most of these pharmaceutical shops, they hand over along with probiotics and other things, So doxycycline,
Yes,
plain doxycycline, there's a problem in shops. They get cheated. That is not going to be effective.
Yes, sir.
I think Dr. Palniraman has told that it's scrub typhus, it's pseudothrombocytopenia, not true cytopenia, because the CBC will show low platelet, smear will show clumps of platelets.
Palniraman is very much there. You can invite him, Dr. This thing.
Yes, sir. I mean, is there? I want him to comment. Or comment on the purchase, sir. But Dr. Palniraman, கொஞ்சம் சொல்லுங்க.
Sir, நீங்க
Palni boss. அவர் வாயை திறக்க மாட்டேன்றாரு. வந்துட்டீங்க, வாங்க வாங்க, மேக்கப்லாம் போட்டு வரீங்க, வாங்க.
எங்க இருக்குது?
அவருக்கு அவலப்பா வந்துருவாரு.
சொல்லுங்க.
ரைட். இது உன் ஸ்கிரீன் இருக்குடா.
இல்ல இது வந்து இவரு நம்ம
ஜெயக்குமார்
இது ஜெயக்குமார் முன்னாடி வந்திருக்காரு. நீங்க சொல்லுங்க நீங்க. சாரி.
அதான் வேற ஒண்ணும் இல்ல. சிபிசில there is no specific count values in scrub typhus. Majority of time it behaves like a typhoid mainly with leukopenia, that is less than 5,000. But platelets, it is not a real thrombocytopenia. Usually when you there is a disparity between the Coulter report and the smear report. This will be the thing in scrub typhus.
It's all wisdom. Words of wisdom from a person who has been there in the field. Thank you, Palniraman, for coming in. And wisdom is shown also there. Good. On your head.
Thank you, sir. Thank you, sir.
What is the dose of azithromycin? Dose of azithromycin?
No, dose of azithromycin. Madam, azithromycin resistance is developing because it is used for also some of the other conditions. So it's better to use doxycycline more in rickettsia.
Like typhoid, do you have eosinopenia here?
No, sir. No, sir. No, sir.
Okay.
No, sir.
Thank you, sir. I think
azithromycin is for 3 days or 5 days in rickettsial.
5 days. Minimum 5 days, sir.
5 days.
Yes, sir. Single dose they have tried, but it didn't give a good response.
Okay. Thank you. Thank you, Lamar.
Thank you, sir.
A nice presentation. Thank you.
Thank you very much, Dr. Ilamaran and our new secretary for a very
well illustrated paper.
Yes, sir. Definitely, sir. A good talk. I think that we are reaching the last topic of someone, Dr. Jaykumar, about whom I understand Dr. Ilamaran knows much better about me than me. So
yes,
I request him to introduce Dr. Jaykumar.
Sir, It's my pleasure to introduce Jaykumar. Jaykumar was one of the bubbling first year resident I had seen. I was senior resident, and he's been quite enthusiastic in his work. And he has progressed as a hematologist. He's currently working as a hematologist in Jaykumar, and he's quite helpful, easy to approach, very easily approachable, and quite knowledgeable. We are eager to look at his work, what he's going to say today about Kawasaki and others. I welcome Dr. Jaykumar for the talk.
Rama.
Thank you, sir. Thank you, sir, for your kind words. Just a minute, sir. Good afternoon, all. A very happy new year for all the faculties and my professors there. Today I'm going to discuss on a topic I felt, which I didn't feel as a common topic when I was doing my residency. But after coming to JIPMER, I felt it is a disease which is existent, and probably we have to be more vigilant about this disease. So the unsuspected offender. I have nothing to disclose. So basically, Kawasaki disease was one which was not that commonly suspected during my UG days. Then it came as probably a suspected disease when there was a fever for an unknown origin. And now probably in the last 2 years of my JIPMERship year, we have found many common symptoms or many common presentations. At the end of the day, were not like common diseases like URA or pneumonia or viral hepatitis, but at the end of the day, it turned out to be Kawasaki disease. So I'll just give you certain cases what we have seen in the last 2 years, where we have actually Googled, or like we found it was like a totally different diagnosis what we reached at the end of our evaluation. So case number 1, actually this was a 3-month-old infant, but actually had come to us with complaints of fever for 2 days, and there was abdominal distension and bilious vomiting for 2 days, and child was actually actively febrile. The temperature was mounting to 103 and 104, and child was having a tender abdomen with reduced bowel sounds, and bilious aspirate was found in the NG tube. So generally when we have this sort of a scenario, we usually think of either a systemic sepsis or a surgical abdomen. And that's what we also suspect in this patient. Maybe he's having a systemic sepsis or a perforation peritonitis or a surgical abdomen which has gone for a peritonitis complication. Or one thing which we commonly see or suspect is Wassermann-induced enterocolitis. And the X-ray of abdomen showed no air under diaphragm, predominantly a dilated bowel loop with mild thickening of the bowel wall and centrally placed bowel loops. So we initially thought, okay, we'll treat it as a gram-negative sepsis. We gave the child supportive antibiotics and we waited. Despite 48 hours or 70 hours of antibiotics, there was no response in terms of the abdomen status, no response in terms of fever status. The child was having persistent fever of 103 and 104. So we were actually puzzled what to do. So this was a presentation like a surgical abdomen in a 3-month-old infant. Another case, an 18-month-old toddler who had come with like high-grade fever, again 103, 104, child has having fast breathing, and there is history of cough and cold for the last 2 days. On examination, child was not toxic. Child was having fast breathing with chest indrawing, and there was bilateral diffuse crepitation, and SpO2 in the room air was 84%, and with oxygen supplementation of 91%. And the X-ray was typical viral pneumonia like picture, like the hyperinflation, bilateral diffuse reticular infiltrates. So again, we thought of, okay, this could be a bronchopneumonia, maybe a viral pneumonia, because the child was not that toxic, maybe okay, a chlamydial or mycoplasma pneumonia as well. Again, this year also we started supportive therapy along with azithromycin. There was no response after 3 days. Child was persistently oxygen dependent. Child was having persistent distress, and fevers are still mounting to 103 and 104. So this is another presentation like a respiratory infection in this case, and still we are puzzled at the end of 3 days of our hospital stay. Still we are not having a clue on what to do. This is the third case, a 10-month-old child who is coming with fever for 4 days. Child is having refusal to feed or play, and there is persistent inconsolable crying, and there are no localizing signs. Again, the child was having high-grade fever. So persistent inconsolable crying and fever, we are going to think of say meningitis or an occult bacteremia or an otitis media. So again, we are doing an LP. LP is totally normal. Autoscopy examination done, that is normal. So we are still clueless. Okay, as a suspicion of occult bacteremia, urine microscopy was done, and there are plenty of pus cells. Okay, we are taking this diagnosis as UTI. We started on IV antibodies, IV amikacin. Child is not showing a response in terms of fever, irritability, and there is persistent fever. Again, here we are puzzled. Okay, we have a case whom we are suspecting as UTI, but still not responding to UTI therapy. Urine culture came sterile. So here also we are puzzled what to do next. This is a 16-month-old toddler who is coming with the fever for 3 days, and there is parotid gland swelling for 1 day, and there is no other localizing signs. Obviously, in this age group, we are going to think of a viral parotitis, maybe mumps, because child was having high-grade fever. We thought, okay, maybe a suppurative parotitis. So we're getting an ultrasound done. There are no signs of any collection inside. The child is having persistent fever. The parotid swelling is persisting even after 7 days of illness, and fever is not responding. So here again, we are puzzled. Okay, what is this? We have a child whom we are having parotitis, but fever is not responding. So again, this is one other presentation where we are not having an answer at the end of 7 days of illness. This is another case, an 18-month-old toddler who is coming with complaints of fever for 2 days, and on day 2 of fever, on an episode of GTCS for 2-3 minutes with active fever. And after the seizure has settled, child is having normal sensorium, no meningeal signs, no focal visit. Obviously, we'll be thinking of febrile seizures here. So we're thinking of febrile seizures. We just want to observe. Child is neurologically doing well, but child is having persistent fever. 2 days or 3 days of hospital stay, fever is not still coming down. We had done all possible investigations. Even CSF was done, that was normal. Urine microscopy was done. So we are not getting any clues in this given case who's having seizures and fever. So we are not sure what is this case. So now case 6, actually a 17-month-old toddler who is coming with complaints of fever for 6 days. There is jaundice and high calorie for 2 days. Child is icteric and febrile, and child is having liver of 4 centimeters. Despite onset of jaundice, there are still persistent fever. We thought, okay, a typical tropical infection, maybe strep typhus, enteric or leptospira. So we are evaluating for that and we are treating for that, not responding. So after 3 days of hospital stay also, there was no response and there was worsening jaundice only. So because there was worsened fever and probably the child was having a liver, we thought, okay, maybe why not an HLH, probably because of an infection. Evaluation for HLH done, classical criteria satisfied. So child is having the criteria of HLH satisfied, child is having fever. So what is a trigger for this HLH? So that we are not having a clue. Are we dealing with this child as a primary HLH? So those are the 2 questions which are there. So then we got another clue, which I'll be discussing down the line. Case 7, we have a child who is presenting with high-grade fever for 6 days. Child is having irritability, and child is observed to have right side hemiparesis and right-sided upper motor neuron facial palsy. So we are doing an imaging that is showing a left gangliocapsular infarct. Okay, we are taking it as probably a pyogenic meningitis partially treated, or maybe a tuberculous meningitis. CSF was showing predominantly lymphocytic pleocytosis and protein was slightly elevated. So we are taking it as probably a partially treated pyogenic meningitis or a tuberculous meningitis. Child has been given therapy despite 3 to 4 days of antibiotics, no response. Evaluation for TB, totally nothing is coming out. There is no contact with tuberculosis, and child is having persistence of fever, and child is having the focal deficit persistently there. So repeat imaging also we planned, okay, maybe it is still tuberculous meningitis. Maybe we are getting any other imaging findings. We are doing that. I'll discuss this case again down the line. So the last case was probably meningitis. Still we are not able to figure out what is that. And the next case was a 11-month-old infant who is presenting with fever with rash for 4 days, and child is having fast breathing, poor feeding for 2 days and reduced on food for the last 1 day. On examination, child is having generalized maculopapular rash with mucosal congestion, a gallop rhythm, enlarged liver, bilateral crepes. So a child with an acute febrile myocarditis. So clinically, because child had rash, we thought of, okay, maybe an enteroviral myocarditis, or maybe a strep typhus induced myocarditis, or at the end of the day, maybe a bacterial septicemia, probably meningococcemia, which is presenting as myocardial dysfunction. So child was given supportive therapy and antibiotics, as well as anti-scrub like doxycycline was also given. Child is showing no response in terms of fever, and child is having persistence of this dysfunction needing inotropic support. So these were the 8 different ways. We had a case where we are not able to get a clear-cut response or improvement despite 3 to 4 days of therapy. So all of the above cases were like a routine case, what you see in any pediatric unit, where you first think of an infectious etiology. All cases we are given an appropriate support therapy and antibiotics, but we are finding no response. We are clueless after 3 to 4 days of hospital stay. Still, we are not able to progress in any direction. And what does the investigation all show? At presentation, the investigation was practically not giving any other clues, because the child was having persistence of symptoms. Maybe another 3 or 4 days down the line into the hospital stay, again the investigations were repeated. And majority of the cases, the investigation was showing anemia, neutropenic leukocytosis, either a high normal platelet count, something like 4.5 lakhs, or something even thrombocytosis. And the child was showing persistently like albumin around the borders, like 3.2 grams, or sometimes even 2.8 grams. So low normal albumin or low albumin. And similarly, AST somewhere between 30 and then somewhere rising up to maybe 60s to 70s. So this is what we have at the end of 4 to 5 days of our hospital stay, which is going to be day 5 to day 8 of the hospital illness. Again, now to disregard these investigations as a routine thing. Say in India, where 60% are anemic. So anemia with high normal thrombocytes are obviously going to be thought of INT-based anemia. A patient is having neutrophilic leukocytosis. Obviously, you think of an active infection which you are not able to figure out. You're thinking of resistance or thinking of some other localized problems. So you're thinking this neutrophilic leukocytosis because of the active infection. And obviously, low albumin, all those things as a part of as a malnourishment or a negative acute phase reactant, where malnutrition is common in India, almost 30%. And there's elevated AST, ALT as a part of topical infection. So this, if we can interpret this as in this direction, still we will be clueless. Okay, we thought, okay, should we think in a different angle? We thought of all common infections and we are still not able to get, so should we think in a different angle? So that's where we had a discussion ourselves. And then the one common thing which is common to all these cases where persistent high grade fever, 103, 104 not responding. We generally don't see a temperatures of 104, 105 unless until there is any suppuration somewhere. And all of these were in the age group of less than 3 years, infancy and toddler age group. And were all showing this sort of progressive rise in thrombocyte count, persistent neutrophilic leukocytosis, progressive rise in AST, gradual fall in albumin, and anemia. So this is where we all put together, we thought, okay, why not Kawasaki disease? So all these cases never gave one of these classical flus. Generally, Kawasaki disease is where we think of rashes as the predominant symptom. The classical Kawasaki is actually only 30 or 40% of what we see. Predominantly, what we see is incomplete Kawasaki disease, where these criteria are not satisfied. So classical Kawasaki is where you have to have 4 of these criteria: a mucosal rash in the oral mucosa, a rash in the conjunctive skin, a congenital suffusion, and peripheral extremity changes in terms of edema, peeling, and lymphadenopathy. Majority of the cases, what I've described, none of them have showed the classical findings. So in our experience, in the last 2 years, we have seen close to 30 cases. Almost 50% of these cases never had these findings during hospital stay. So these are the classical findings of a congenital suffusion, oral rash, mucosal tongue rash, and the patient is having edema, peeling. So none of these findings were there in 50% of these cases. But again, this is what the criteria also says. Many times you have to go back, ask did they have those lesions at home. So when they present to us, those lesions could have resolved, or they may develop during the hospital stay. So at presentation, they may not be there, but always we have to probe whether those things were present in the past to them, or we have to anticipate whether those things are developing in them. So how then to work up a case of incomplete Kawasaki disease? Obviously, you'll do a CRP and ESR, and these are the 6 parameters which we have to do: HB, platelet counts, albumin, ALT, WBC count, and urine microscopy. So why to identify incomplete Kawasaki disease? This is more common and it is more difficult to identify. And more early you identify these patients, better you prevent them from developing a coronary artery abnormality. And majority of these cases are associated coronary artery abnormality. So what happened to our cases? So our case number 1 was having that intestinal obstruction like feature. When we look closely, we found that patient was having this BCG site erythema. This picture is actually the healed BCG site where we are having only the hyperpigmentation 95. The patient was having, on close look, then we found this patient was having erythema. So from there we started, okay, why not a Kawasaki disease? We got an echo done, and the echo was showing an aneurysm in the left main coronary artery and right coronary artery. And this image you can see the left anti-descending artery, there is no tapering of the vessels. The vessels are almost in the same size. So it's just not aneurysm which should be present. Even failure of the coronary arteries to taper, presence of pericardial effusion, myocardial dysfunction, valvular regurgitation, or aortic root dilatation. So these could be a manifestation of Kawasaki disease. So in our patient, we had aneurysm and failure of tapering. So then we cracked, okay, this is a case of Kawasaki disease which has presented with intestinal obstruction like feature. Case number 2, the child was having persistent fever, the child was not responding to antibiotics. Okay, so then what we did? So we just had a CBC which are showing slightly worsening platelet counts and worsening enzyme levels and falling albumin. there was a trend towards Kawasaki disease. Okay, then we thought, okay, why not a Kawasaki disease presenting as a pulmonary disease? We gave IVAG and the patient showed a good deference and patient became distress free. So this was a very challenging case for us where we had no clues and we just had to shoot at the dark, where we had a typical LRI who's not responding. The case number 3 who was having typical UTA-like features in terms of urine microscopy and child was having persistent fever and irritability. So we had no clues, but again, the worsening trends of acute phase reactance was present. And on day 7, we got an echo done, which was showing coronary artery aneurysm. So we treated this patient on day 7. Again, the point I would like to stress here is we allowed the patient to develop coronary artery aneurysm. Had we been more vigilant, probably we could have prevented this. So that is what is the ultimate objective of identifying a Kawasaki disease before they develop an aneurysm. The case number 4 was having that persistent parotitis. So again, this patient was having no suppuration. So this child was showing the typical worsening trend of acute phase reactant. The AHA criteria for the incomplete Kawasaki disease is satisfied. We again treated this child with IVAG. This child was responding very well and the parotitis improved. We were lucky enough to prevent this patient from developing a coronary artery aneurysm. And the case number 5 was having that febrile seizures. So on day 3 or 4 of the fever, child was starting to show the classical rash. So then we cracked and this child was in case of Kawasaki disease. So at presentation, there was no rash, but during the hospital stay, the child showed rash. So it may not be present at presentation, but may develop later. Case number 6 was having the criteria satisfied for the HLH. This child was having persistent fever. There was no consanguinity in the family. So the chance of this child being a primary HLH was low, but still not ruled out. The child was having persistent fever. So we had no choice, but we just, as a part of screening, we just did an echo that was showing a coronary artery aneurysm. So from there, we diagnosed this patient as having Kawasaki disease. So Kawasaki disease can present as acute hepatitis and with macrophage activation syndrome as well. So whenever you have a child who is having something like an HLH or macrophage activation syndrome, think of Kawasaki disease. That could be a Kawasaki disease as well. Probably this child was, if like 2 or 3 months, maybe you will not have thought of even to do an echo, you would have thought of primary HLH. Since this child was around 18, 19 months, not a classical age for a primary HLH, that's where we did an echo. So think of Kawasaki disease when you have an acute febrile hepatitis, not responding to your routine therapy, not able to find an answer, go for an echo. Case number 7, where we are thinking of partially meningitis, no response to antibiotics, TB violation, totally non-contributory. Okay, we are having person fever, going for repeat MRI. There was no basal exudates, no hydrocephalus. By and large, in TB meningitis, some basal exudates will come after day 11, day 12 of illness. And one important finding was like sensorium was relatively well preserved. And again, this patient was showing a progressive worsening trend of acute phase reactant. So we got an echo done on day 14 showing an aneurysm. So again, this case, we have missed the bus. It was too late by the time we diagnosed, but still at least diagnosed on day 14 of illness. And case number 8, where the patient had presented with a typical myocardial dysfunction, all the evaluation for tropical infections came negative, enteroviral PCR came negative, so he was still clueless. Again, the acute phase reactant was showing a worsening trend. And echo on day 7 was showing a coronary artery aneurysm. So Kawasaki disease can present as myocardial dysfunction. So as Purachikari Bhardiya சொல்ற மாதிரி இனி ஒரு விதி செய்வோம். So the one general thing what we right now in our department do, whenever we have a patient who has a typical infection like presentation, but he is not showing a response to routine therapy, he is of an infantile or toddler age group, the fever is like 103, 104, and one important finding, we are finding irritability. We always inspect the BCG side, we inspect the perineum, because that will be the first thing that rash will be starting from. And always we probe the history again, was there any rash present or not? And we give a lot of emphasis on this markers which are worsening. So generally on day 3 or day 4, we repeat the markers again to see if they are showing the worsening trend. If the moment they are showing worsening trend, we really suspect a Kawasaki disease. We straight away go for an echo. Most times we have got it right. So Kawasaki disease is still common, and incomplete disease is more common than the complete form what we routinely think of. Don't wait for the criteria to be satisfied. Like many times the platelet count should be more than 4.5 lakhs. You may not reach that 4.5 lakhs, but you'll see the trend. At presentation, the platelets would have been only 2.5 lakhs. But on day 3, day 4 of hospital stay, you'll find the values rising towards 4 lakhs, 4.5 lakhs. So worsening trend also should alert you. And always when you are suspecting that, go for an echo. Many times you'll get a lot of clues from that. And obviously this criteria is still evolving, and newer specific laboratory markers are on the horizon, which will give a more confident answers for us. And obviously it is important to go for early treatment, because it is very important to prevent coronary artery aneurysm developing, because it has long-term sequelae. And this is Professor Tomisaku Kawasaki in his first Sentinel Present paper in 1967. We are now 50 years from that description and almost 40 years from the first case report in India in 1977. Thank you for your patient listening.
Thank you, Dr. Jayakumar. There are a few topics which we can say eye-opener. So I would definitely say this was an eye-opener for me. Like this is a common scenario we all come across. So thank you, Jayakumar, for your eye-opener topic. Sir, Madhavan sir.
I think it's nice to hear Jayakumar. And, 2 months back, we were in touch with Arun Gopalakrishnan, who's in Sri Chitra, and also Avinash, who's in Jipmer. I think the same picture had been emphasized by them also. And is there any overlap with Corona picture, Jayakumar?
So what our case discuss is all like the pre-Corona, sir. Right now, after the onset of Corona, we are definitely had a significant surge. In the last 8 months of our tenure, like we had almost 15 to 18 cases of MASC, where majority of have significant rashes. The classical thing, both in MASC as well as in Kawasaki disease, what we found in common was definitely the spikes of fever. Like 103, 104 is what is continuously it is coming, which we don't generally see in many other infectious diseases. That is one. And MASC many a times has presented with a good significant rashes, cutaneous rashes, subconjugal bleed. So all those are definitely there. And obviously by day 4, day 5 of illness itself, many of these MASC patients have shown coronary aneurysm rather than the classical textbook description of Kawasaki disease where you get aneurysms after day 7. So more early onset of aneurysms we have observed in this MASC. Lab markers, this thrombocytosis, all those things are not that commonly seen in MASC. So again, this past history of COVID or currently somebody with COVID. So that was one thing which led us towards MASC. But both are like in two different angles. Kawasaki disease is having a lot of elevation of lab markers, whereas MASC is not showing a lot of thrombocytosis, but they are showing a lot of elevation of D-dimers, pro-BNP elevation, which we don't routinely see for Kawasaki disease.
Because it's nice. Dr. Surjit Singh used to emphasize on the induration of the BCG site. I think he even wrote that in BMJ editorial. Here you had shown more of an erythema around the BCG site.
Yes, sir.
Yes, that is
actually, this was the healed one, sir. When the child came, there was definitely a good amount of induration. Actually, we missed it. We initially were more into the abdomen examination. Nobody really paid that much of attention to the BCG site.
BCG and perineal.
There was induration with erythema.
Very good. And if I can share with other people now, I think Jayakumar won the PG quiz in Gurgaon National Conference of IJP. And he and Arun Gopalakrishnan, both of them, we traveled and then they both won the PG quiz. Remember Jayakumar?
Yes, sir. Yes, sir.
And I think it
was in 2011. Yes, sir.
Yes. So nice to hear.
Thank you, sir.
Yes, sir.
Yes. Jayakumar, it was a wonderful presentation and very good eye-opener. 2 to 3 points I want to emphasize. And with regard to Corona, MASC and the Kawasaki, two differences. The Kawasaki is the younger age group, whereas MASC mostly school-going age group and older age group, number one.
Yes,
number two, with respect to Kawasaki, all the CBC markers will be elevated along with the that is CRP level. Whereas in case of MASC, the CBC can be normal, only the complex that is CRP will be elevated. That is the only clue. That is the only clue. And regarding the Kawasaki disease, you have presented as early as 2006, Dr. Surjit Singh, who is the father of Kawasaki in India, as early as who has sensitized us in the Kawasaki disease by 2006 lecture. And he has recently come out, any fever without focus in a younger age group with raised acute phase reactants always have Kawasaki in the back of the mind. Now, fever without focus, now the olden days we used to think about occult bacteremia, now always think about occult Kawasaki at the back of the mind.
Yes.
And all UTI are not real UTI. It can be a sterile pyuria with Kawasaki. Always, whenever you can have this thing. And all jaundice are not infective hepatitis. It can be atypical presentation of Kawasaki. These are 2 to 3 things which usually Kawasaki. And any myocarditis with the shock. Nowadays, Kawasaki is coming with the presentation of shock-like presentation. Be careful. These are the 4 things he recently emphasized in the last lecture, I think so. These are the things I wanted to tell the August audience, because any fever without focus, be careful. It cannot be a simple thing like UTI, pneumonia, and other things. It can be Kawasaki too.
Thank you, sir.
I can also talk about probably the first case of Kawasaki which we saw in Jipper in 1998. I still remember it was on Unit 1, and one of our seniors, Dr. Jamana, has admitted the case as a child with fever and pneumonia. Dr. Mahadevan Kalla on the first bed, first cubicle. Then we didn't have the PICU. And then he said, pneumonia va, it doesn't look like pneumonia. So sir was just walking through. He just looked at it and he told and went. Then actually Dr. Srinivasan came and then he listened. I didn't know what it was. And that is why I remember now. So actually Dr. Srinivasan came and then he auscultated and then said, this is a pericardial rubber. This child has got pericarditis and not just a plain pneumonia. So then we actually took the child for an echo, which showed a large aneurysm. We gave then IVGG and child became better. So even our first case was always something which we didn't really look for. We picked up because of clinical acumen by some senior people. So yeah, it's always been diagnosed probably which we have missed for a long time. Thank you, sir.
Thank you, sir. Yeah, we can. I mean, these kind of scenarios are the ones which keep us engrossed to our pediatrics, sir. We have always learned from our teachers, and thank you to all my teachers, sir. Sir, I would like to share a few words. Dr. Sandil has joined us, sir, our IAP president. If he can say a few words.
Sandil, sir.
Sandil, sir, you are there, sir.
வணக்கம் அனைவருக்கும். Sir, வணக்கம், Professor Mahadevan. I think Viluppuram Pondicherry branch has started this year with a bang, I would say. And I think with fresh and who are really interested in IAP, I think they are going to do wonders, and wish them all the best and all throughout the year, and we are there to help them. Thank you so much for the opportunity.
Thank you, sir.
Thank you, sir. So a couple of announcements to make. One, because we apply for TNMC credit points, and so we request you to fill the form. The form has been put both in the WhatsApp group and in the chat box here. So if you want TNMC credit points, kindly request you to complete the form and fill it. For this time, we are not being New Year gift. We are not paying anything. So we request you to kindly fill the form to make sure that we can apply for credit points. Number one. And number two, after this CME is concluded, we are going to have chat about our Puduvai Pedicon. So I request all of you to stick around for another half an hour. So please don't quit. But actually, the Puduvai Pedicon proceedings will not be live on YouTube. So we'll stop live. It will be discussed only in the Zoom. Please request you to stay back. Yeah, Dr. Ilamar.
Yes, sir. Before we go for vote of thanks, I would like a few members we have left out. Our